Hello, I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University, and I'm absolutely delighted to have AJ Blood, a cardiologist as well as a critical care research fellow from Brigham and Women's Hospital in Boston. Welcome, Dr. Blood.
Thanks so much for having me.
We are here at AHA 21 to talk about your exciting digital care transformation study. Can you start by telling us a brief rationale for the work?
Sure. Hypertension and hyperlipidemia, extremely common conditions, contribute significantly to the development of atherosclerotic cardiovascular disease. We'd found that our patients and studies have shown that 30 to 50% of patients don't achieve guideline-directed targets for hypertension and hyperlipidemia management, even though most treatment options were generic. So we looked to develop a digital program and platform to allow for more streamlined communication, medication prescription, and monitoring that would allow patients to more easily and seamlessly reach their guideline-directed targets and reduce their cardiovascular risk.
Fantastic. Tell us about some of the eligibility criteria for enrollment in this study.
Absolutely. So our patients were followed longitudinally in the Mass General Brigham Health System. So they had to have a provider within Mass General Brigham who they've seen within the past 3 years. At that point, a few exclusion criteria: an eGFR less than 30, severe aortic stenosis, known heart failure with reduced ejection fraction, were all exclusion criteria. Other than that, patients could either be identified by electronic health record screening or by provider referral to be enrolled and managed in our remote algorithm-driven hypertension and lipid management programs.
And I remember from your presentation that pregnant and lactating women were also excluded. What was the rationale for that exclusion?
Some of the therapy that we use as part of our algorithms included things like ACE inhibitors, therapy that hasn't been approved for use in women who are pregnant or lactating. So because of those potential contraindications to therapy, those patients were excluded if that was made clear at the time of their recruitment into the program. That's a good point.
Yeah, because they could have been provided other therapies as they're a high-risk group and potentially have more to gain from digital health services since they have competing demands and scheduling. Just a thought for future initiatives, certainly something that we're looking to build, but these implementation projects can be so challenging to reach the spectrum of patients that we'd like to provide services to. What kind of equipment did patients need to engage in this study?
Great question. No requirement for equipment. The program did provide blood pressure cuffs at no cost to the patients. And depending upon the patient's comfort level, those blood pressure cuffs were either Wi-Fi enabled, Bluetooth enabled, or enabled just through cellular technology that allowed for the wireless transmission of data back into the system that allowed us to manage them remotely. And just a quick the patients who were pregnant, just to get back to that for just a moment, we did like to afford the opportunity for those patients to still participate. So if they were ineligible at the time of initial contact, we would reach back out to them if they were willing after the period of which they were ineligible for active management with the medical therapy that we did provide. But you bring up a very good point. I just wanted to highlight that we didn't exclude them forever, only during their period at which our algorithms were not engineered to fit their needs. But thank you for that point.
Now tell us how many patients you screened and how many were enrolled in the two groups that you intervened on.
Absolutely. So we started out with around 28,000 patients that were identified by electronic as a cohort to start working from, patients longitudinally followed at Mass General Brigham. After the electronic health record screening with some of the exclusion criteria that we mentioned, that got down to about 20,000 patients. Of those, we've reached out to about 18,000, and of those 10,000 or 10,800, around 11,000 patients agreed to participate in the program. Now, of those patients, about 1,200 preferred to engage only in dietary and lifestyle advice, management without further initiation or titration of medical therapy, leaving about 9,600 patients who had medical therapy initiated or titrated as part of the study.